considering specific pathologies, the physician must observe the patient's physical state and place them into one of two broad domains. The first domain is the hyperkinetic state. This is characterized by an excess of involuntary movement. If you observe irregular, dance-like motions, you're seeing chorea. If you see sudden twitches, those are tics, and sustained twisting muscle contractions indicate dystonia. The second domain is the exact opposite, the hypokinetic state. Here, the defining characteristic is a pathological restriction, a noticeable slowness and poverty of movement. This animated diagram maps that precise macroscopic dichotomy. On the left, we see the erratic, high-energy waveforms of the hyperkinetic group: chorea, tremor, tics, myoclonus, and dystonia. On the right, the energy drops, representing the slow, damped waveform of Parkinsonism. Once a patient is mapped to that right side, the primary clinical task becomes differentiating the various forms of Parkinsonism from one another. The first step in diagnosis is not immediately naming the disease. It is properly identifying the fundamental energy state of the patient's movement. Parkinsonism is a clinical syndrome defined by a specific triad of symptoms. However, these symptoms are not weighted equally in the diagnostic criteria. The absolute, non-negotiable core feature is bradykinesia. This is a progressive slowness of movement accompanied by a decay in amplitude as the patient attempts repeated actions. Accompanying this core are the secondary clinical manifestations. These typically include a resting tremor, beating at roughly 3 to 5 Hz, and increased muscle rigidity, often presenting as a cogwheel or lead pipe resistance during examination. These documentive learning outcomes highlight exactly what is required: the ability to establish a clinical diagnosis of Parkinson's disease while accurately recognizing its secondary features. You will frequently see postural instability presented as a clinical test feature. While it is associated with the disease, early postural instability is a severe warning sign. In true idiopathic Parkinson's disease, falls and instability are late-stage developments. Without observed bradykinesia, a diagnosis of Parkinsonism cannot be made. It functions as the anchor upon which the rest of the clinical assessment depends. Because several neurodegenerative and secondary conditions mimic Parkinson's disease, clinicians rely on a system of red flags to filter out imposters. Idiopathic Parkinson's disease has a highly specific clinical fingerprint. It begins unilaterally. The symptoms remain definitively asymmetrical throughout progression, and the patient shows a dramatic, rapid improvement when given levodopa. This clinical funnel illustrates how the filter operates. If a patient profile drops in showing symmetrical symptom onset or a history of early falls, these act as red flag blockers, immediately routing the diagnosis away from idiopathic disease and into the atypical or Parkinson plus category. If the patient history reveals the use of dopamine-blocking drugs, specifically neuroleptics or antiemetics like prochlorperazine, the diagnosis is routed towards secondary Parkinsonism. Furthermore, if physical examination reveals a vertical gaze palsy or clear cerebellar signs, these are pathognomonic markers. They firmly place the patient within the Parkinson plus syndromes. Even if the initial presentation looks typical, a poor or entirely non-sustained response to levodopa is a definitive signal that the underlying pathology is not idiopathic Parkinson's disease. Securing a diagnosis of idiopathic Parkinson's disease requires rigorous observation to ensure that none of these red flag clinical features are present. Once the clinical filter isolates idiopathic disease, we have to look past the physical examination and examine the neurobiology of the substantia nigra. This animation displays the exact mechanism of the disease. Dark protein aggregates progressively accumulate inside healthy neurons, eventually triggering cellular degradation and neuronal death. Those aggregates are the pathological hallmark of the condition: misfolded alpha-synuclein proteins, clinically identified as Lewy bodies. As these Lewy bodies destroy the dopaminergic neurons located within the substantia nigra pars compacta, the brain loses its primary supply of dopamine, directly initiating the hypokinetic state. The macroscopic slowness you observe in the exam room is the direct mechanical result of this microscopic dopaminergic drought. Treating this dopamine deficit requires a highly strategic approach. The physician must match the specific pharmacological agent to the exact symptom causing the patient's impairment. As detailed in these management outcomes, the basis of pharmacological treatment must relate directly to the dopaminergic pathway. For the core symptom of bradykinesia, the gold standard treatment is levodopa, administered alongside a decarboxylase inhibitor to prevent premature breakdown in the bloodstream. However, other agents have strictly defined niche roles. Anticholinergic drugs, such as benzhexol, are indicated solely for tremor control. This grid maps the strict relationship between drug classes and symptom targets. Benzhexol routes directly to tremor, while levodopa is required to target bradykinesia. It is crucial to understand that anticholinergics provide zero significant clinical benefit for the life-limiting rigidity or slowness caused by the disease. Without precision in identifying the specific movement deficit during the exam, precision in pharmacological selection is impossible. While levodopa is the most effective drug available, prescribing it introduces a management paradox. Its utility comes with a strict time limit. Returning to our management criteria, notice the specific requirement to base the choice of therapeutic intervention on both the age of the patient and the stage of the disease. Continuous reliance on levodopa yields a window of effectiveness of roughly 5 years. After this period, the medication inevitably induces severe motor fluctuations and involuntary dyskinesias. Because of this limitation, the strategy for younger patients, or those with very mild presentations, involves delaying levodopa. Instead, clinicians utilize dopamine agonists, like pramipexole, to manage early symptoms. By contrast, if the patient is elderly, or if the disease has already caused severe functional impairment, preserving future treatment windows is secondary. In these cases, levodopa becomes the immediate first-line choice. This graph plots the timeline clearly. Along the x-axis of disease progression, the motor response remains stable until year 5, at which point the fluctuations spike erratically, representing severe dyskinesia. Balancing immediate symptomatic relief against the long-term risk of drug-induced motor instability turns Parkinson's disease management into a complex temporal chess match. We can test this logic by applying the diagnostic and management principles to a concrete clinical scenario. Consider the case of a 67-year-old man who presents to the clinic with a 6-month history of progressive stiffness and a resting tremor. This exam question outlines his specific examination findings: resting tremor, bradykinesia, hypomimia, and increased muscle tone in the limbs. Based on this presentation, you must identify the absolute core clinical feature of his disease from that list. The correct answer is bradykinesia. While the resting tremor and increased muscle tone confirm the presentation, bradykinesia is the single non-negotiable requirement for a Parkinsonism diagnosis. Moving to pharmacotherapy, this patient is 67 years old and already exhibiting progressive, functionally impairing symptoms. Therefore, initiating levodopa, often prescribed as co-careldopa, is the most appropriate and effective next step. In a real-world environment, securing this diagnosis requires taking the entire symptomatic profile and filtering it strictly through the hierarchical rules of the Parkinsonian triad. To summarize the clinical algorithm, first, classify the movement as hypokinetic. Second, verify the presence of core bradykinesia. Finally, aggressively filter the presentation for red flags. Once diagnosed, pharmacological intervention follows a strict rule: target the specific symptom with the correct mechanism, but time the drug initiation based carefully on the patient's biological age and disease severity. Remember that clinical outliers, like early postural instability or vertical gaze palsy, are not minor deviations. They are massive diagnostic pivot points that rule out idiopathic disease. Successfully managing Parkinson's disease requires correctly identifying the neurochemical deficit and strategically deploying dopamine replacement to maximize the patient's functional lifespan.